Hi, I'm Dr. Annie Doughton, and I'm the Director of Addiction Medicine at Hartford Hospital. Today, I'll be discussing the neurobiology of alcohol withdrawal. Acute alcohol withdrawal syndrome is a prevalent complication of alcohol use disorder. Up to 50% of individuals with alcohol use disorder will experience some withdrawal symptoms upon cessation of or significant reduction in alcohol use after chronic, regular, heavy use. Individuals who are consuming 4 or more standard drinks per day for 4 or more weeks, and those with patterns of binge drinking, 4+ drinks in one sitting, more than 3 times a week, are higher risk for experiencing alcohol withdrawal syndrome. A prior history of alcohol withdrawal syndrome is also a risk factor for an individual to experience withdrawal upon cessation of or significant reduction in alcohol use. Healthcare professionals across various levels of care, including clinicians in ambulatory settings and those in acute care settings, will encounter patients who require treatment for this syndrome. There are screening tools to help clinicians identify which patients are at risk for alcohol withdrawal, and furthermore, to guide the decision about what level of care any given patient might need for withdrawal management. Once an appropriate level of care is established, there are also different treatment algorithms for medical management of acute alcohol withdrawal syndrome. Comprehending the underlying neurobiological mechanisms that drive alcohol withdrawal syndrome will enable clinicians to better understand the rationale behind the most commonly used treatment algorithms. There are several neurotransmitters involved in acute alcohol withdrawal syndrome, but we will focus on the main 2. In a very simplified overview, picture a seesaw or a scale that is perfectly in balance or level. This represents the human brain in an alcohol-free state, where there is homeostasis between the main neurotransmitters that are responsible for inhibition versus excitation. On the one side, we have the main inhibitory neurotransmitter, gamma-aminobutyric acid, or GABA, and on the other side, we have the main excitatory neurotransmitter, glutamate. Alcohol acts as a GABA agonist, meaning it binds to and activates or increases the activity of the GABA receptors. As the main inhibitory neurotransmitter, when there's more GABA around, we see increased inhibition. Things are slowed down. It makes sense that in the acute setting, alcohol consumption or intoxication, which causes increased GABA activity, leads to symptoms such as sedation, slowed or slurred speech, and impaired coordination. With chronic alcohol use and regular deviation from the normal homeostatic steady state, i.e. a level seesaw or a balanced scale, the brain makes changes in an attempt to restore balance. There's downregulation of the internal inhibitory GABA system and upregulation of the internal excitatory glutamate system. The brain makes these changes to the internal balance of things to account for the persistent presence of extra GABA that results from alcohol consumption. When alcohol consumption is stopped or drastically reduced, within 4 to 12 hours, the seesaw or scale tips in the other direction because the extra GABA stimulation from the alcohol is suddenly gone. The body has suppressed the endogenous GABA system, which means there's now too little inhibition. It's also ramped up the endogenous glutamate system, so there's too much excitation. This new disequilibrium results in the clinical symptoms we see with alcohol withdrawal: anxiety, tremors, agitation, nausea, and in severe cases, seizures and sometimes delirium tremens. This graph depicts a general timeline of when specific symptoms tend to occur. Minor symptoms, including nausea, agitation, tremors, and autonomic hyperactivity, can start as soon as 6 hours after cessation of or significant reduction in intake and can last for up to 72 hours. Seizures are also an early symptom, occurring anywhere from 6 to 48 hours. Hallucinosis, including visual, auditory, and tactile hallucinations with intact orientation, peak around the 24 to 48-hour mark. Delirium tremens typically begins anywhere from 48 to 72 hours after the last drink or significant reduction in consumption. Essentially, with abrupt cessation of or sufficient decrease of alcohol use after a period of long-term, regular, and heavy consumption, the patient now has a relative deficit of GABA. This informs the primary treatment strategies used for management of alcohol withdrawal syndrome. By giving the patient GABAergic medications, such as benzodiazepines or barbiturates, we treat this GABA deficit. These medications can be tapered gradually with the goal of leveling out the seesaw and restoring it to a steady state. As the brain works to restore true homeostasis, patients can experience persistence of milder or more subtle symptoms, including anxiety, depression, and insomnia, to name a few. This is known as post-acute alcohol withdrawal syndrome, and it can last for weeks to months beyond an acute alcohol withdrawal episode. Remember that acute alcohol withdrawal syndrome is a complication of an underlying alcohol use disorder, and withdrawal management alone does not equate to adequate treatment of the underlying chronic medical condition of alcohol use disorder. Patients who are treated for acute alcohol withdrawal syndrome should be offered medications for alcohol use disorder, or MAUD, to promote recovery after the management of withdrawal symptoms is complete.